pleased to be joined now by Dr. Gilles Dreyfus. Gilles, as you know, is an expert in cardiac surgery, but especially of the tricuspid valve. Tell me a little bit about, it's secondary tricuspid regurgitation is something I think we haven't paid enough attention to as cardiologists. You as surgeons maybe have, but it's becoming more and more prominent.
Well, I think that we started more than 20 years ago. I was surprised that these tricuspid orifices, when we happened to look at them, they look to be extremely dilated. And then if you look at the physiology of the right ventricle, you see that really it has nothing to do with the left ventricle. Basically, there are many factors that vary, such as preload, afterload, and right ventricular function. And it's obvious that if you treat a patient with diuretics for 2 days, you can bring a TR grade 3 to a mild TR. And therefore, relying just upon echocardiographical grading seems to me a great mistake. And then we started from that point and systematically looked at the tricuspid annular dilatation. From that point, we had a rather, I would say, radical policy, which was to treat all patients for a long time period, over 10-15 years, who had an annulus that was greater than 70 millimeters intraoperatively. Because, again, we were at the time where echo was not paying attention.
Right.
I mean,
you're exactly right.
Let's come back to where we come from. Most of the patients with mitrals, the echo report didn't even look at the tricuspid, didn't even mention the tricuspid.
Absolutely. No, you're absolutely right.
And then we paid attention to what we could see. And when we were sure, and then has been many articles coming from the cardiologists saying that, yes, TR grading is not reliable. So basically, how do we do with this? What should we do? There is a risk, which is obvious, and I can see now from all this is, well, some people say, well, then he advocates to prophylactically treat all tricuspid. No, I wouldn't dare say that. But what we don't know is exactly what is the size, which is the threshold where we need to treat the tricuspid. What we don't know is what is the size when we chose arbitrarily 70.
Right.
And we've seen that among the group that was not treated below 70, but I didn't measure every size, so I can't give an average. This was on-off process. Well, there were about 45 to 50% of the patients who developed significant TR in the follow-up of 10 to 15 years. Right. It becomes even more difficult when you know that you do not know, A, when to operate and when to treat at initial stage, but it becomes more difficult when you have an isolated secondary TR after a left-sided heart surgery. When would you go back to treat it? And we know how high the mortality is, because if you wait for liver dysfunction, renal dysfunction, coagulation...
Which is usually what people do. I mean, they get these people come back after a left-sided valve, and 10 years later they've got severe TR, neck veins up to here, and they treat them. And we wait too long in those people.
So you will see at this convention, I've tried to be very cardiological and not to be surgical at all, because I don't think surgery is a great deal or a challenge. I was very much interested by a paper of McCarthy, which was a few years ago, and showing that upon many hundreds of patients, he showed that he had more than 15% of the patients after even a week who showed significant TR, close to severe, after annuloplasty. And this was an argument for a lot of people to say, well, why then put a ring? It's useless. I think this is a wrong statement. I think that from now, I think we should, and what I would suggest, but of course, as a surgeon, I would do it with a bit of being very careful not to exaggerate.
You're politically correct, that's right.
But I think we should pay attention to annular dilatation, and where the threshold, 35, 40, I don't know, in 4 chambers view. We should pay attention to the mode of leaflet coaptation, which is either very high, so you have plenty of margin of safety margin, or you have an edge-to-edge, you know that then you have no safety margin, or you have no coaptation at all.
Right.
And then there's a new thing which we need to pay attention to, is whether there is a tethering or not. which I think is a real entity. This has been well shown by Kim
yes.
from Korea. And he has published very interesting articles where he was the first to say, well, I think that if the tethering height is greater than 8 millimeters, it is an entity. And I do not know whether 8 or 10 millimeters is the threshold. What I can say is that once you have a tethering, if you just go and put a ring, this is the reason for early failure.
Right, okay.
So then you need, so basically it seems that today, to me, we should revise the grading of the TR. I don't think anyone can say that there's a difference between mild and moderate. It's very difficult. We all know what is severe, we know what is none. In the middle, there is a gray zone. I think we should rather say there is no mild, there is moderate mild, and there is severe, which is more realistic. So we should change also the classification. Should look at the mode of coaptation, should look at the tethering or no tethering, we should look at the annular dilatation. And once you've seen all these lesions, you can figure whether you should treat the patient.
What do you need from your echocardiographer? In other words, what are you looking for? What do they tell you? Are they measuring annulus from a four-chamber
They're measuring
view?
annulus, four chambers view, they're measuring the coaptation height, they're measuring the tenting surface, the tenting height, the tenting area. They're measuring the TAPSE to see whether the right ventricular function is good. We also will show, because it's very recent data that I have from Monaco, because you know that I have, for the tethering, I have proposed to enlarge the anterior leaflet with pericardial patch.
Right.
Because if you cannot achieve the coaptation in the ventricle, the best way is to increase the size of the leaflet and to achieve coaptation not in a physiological way, but down into the ventricle. And you can see that you have a really significant reverse remodeling as early as a week after surgery. So there is really an effect. You can reverse, the right ventricle has a tremendous capacity to reverse its dilatation and to reverse its remodeling.
And your techniques, obviously, with the tethering is, and you've just mentioned a different technique, but the De Vega annuloplasty, all that, the pericardial annuloplasty, those are all gone.
I think they're all gone, because basically, I think, again, if you treat only TR without understanding how the leaf, but I think, it comes all from the mitral. I mean, today, who would treat the mitral by just saying there is a regurg? You need to understand why there is a regurg.
Absolutely.
Is it because you have a tethering of the posterior leaflet? Because you have a prolapse of the anterior leaflet? Is it because you have a bileaflet prolapse? Well, basically, I'm saying the same. You need to understand what is the mechanism of the leak, and then you do what you want, what you have to do. But annular dilatation, of course, in the functional TR is most often the key factor. Now, the advantage of the ring is that it is a reproducible surgery. When you see the bands, when you see the others, basically, if you shrink the orifice, it doesn't mean that you will achieve coaptation. And I think De Vega himself, in many public confrontations we had, where I admire him because I think he was the first to address tricuspid. I'm not saying anything against this technique, but said clearly that it was not to address severe annular dilatation. And if you reoperate some patients with De Vega technique that have failed, and they do tend to fail after a certain time, then you have a guitar string effect of the leaflets, and sometimes you then have to replace the valve. So, but again, I don't say replacing the tricuspid valve, again, depends the age of the patient. If you're dealing with a 75-year-old person who's got a huge, massive heart, going to put a bioprosthetic valve in 10 minutes is probably a reasonable option rather than doing a complex repair.
Right.
But the problem is that, again, we do not know, and then we come back again to the same process. When do you have to change a valve? How much do you impair further the right ventricular function by changing the valve? Should you keep the septal leaflet? I surely not keep the anterior leaflet, because the anterior leaflet is the one which is this with the anterior papillary muscle is attached to the anterior wall, and you've seen this huge right ventricular dilatation when they fill. The papillary muscle goes down, 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 and tethers the anterior leaflet and avoids coaptation. it's very obvious.
Well, I mean, you make it, all your points are incredibly important. I mean, I think for the cardiologists, the imaging cardiologists, they really have not thought about the tricuspid valve, and so it's really very important when we're thinking about evaluating patients with left-sided valvular heart disease to really begin to understand what you're telling, the mechanism of the TR as well as the severity of the TR.
And really, I think the biggest message is not to rely on grading, because the grading is labile.
Right, absolutely.
The grading varies because of the filling, because of the use of diuretics, because of the left heart function, because of the right heart function. We cannot control any of these parameters.
Absolutely.
We do not know what is, quantify them. We do not have any correlating factor to adjust patients one to the other. Therefore, the grading is meaningless. It is an indication that at the stage where you analyze a patient, there is something going wrong. But if you do not look at the coaptation, why there is a leak, what is the right ventricular function, then I think you misled. And then just putting a ring, it will work sometimes, it will not work some other times, and then you will have unreliable results. And that this is in the era of today, I think it's not acceptable. But I think what is interesting is also what we have shown, and seems to be correlated with other studies, is that we improve quality of life.
Absolutely.
We do not have, we have been unable to prove that we were improving life expectancy because probably the numbers of the patients and the follow-up has not been long enough. I do personally believe that we should be able to prove at one stage that we improve life expectancy. However, as this disease is also very difficult to diagnose and to establish unless you have end organ dysfunction such as renal dysfunction or liver dysfunction, I think that again, you know, there's a paper from the Mayo Clinic saying that you don't need to treat it. They prove exactly the opposite, because on 109 patients out of 696 patients, they have a 30% rate at 5 years, only in 100 patients who show severe TR. So they reach exactly the same conclusion as we have reached. Now, the only question, and then the author says, Yuri says, well, you know, we reoperated only one patient, but on which ground do you decide to reoperate a patient? This is, again, a very important thing. We believe that if you have, there is a very interesting index called MELD, which is for end-stage liver disease, used by liver surgeons. And if you have an INR, which is perturbated spontaneously, if you have a bilirubin, which is raised, and if you have a creatinine level, which is high, well, these patients, if this index is higher than 15, they have a close to 20–30% mortality, and I think those patients do tend to die. We had 2 in our group who were in this range. I do not think that pulmonary hypertension plays a role. I think that it is something else. If you have a right ventricle which is failing,
it's a physiological event.
Yeah,
I mean,
you know,
anatomic physiologic.
If you have a ventricle which can provide 60 of pulmonary pressure, well, the right ventricle is not so bad. It's very rare that a very poor right ventricle
it's like
cannot.
gradients.
Exactly.
Same thing.
So, you know, pulmonary hypertension, I'm not so worried about it. TAPC below 10, yes, I start to be very worried.
And liver function. What's
and
happening
liver
to the
function.
liver.
And liver function.
Well, you've done a great job of educating all of us about the importance, and I like where you've gone in this little discussion of saying it's not just annulus, that you need to look at all that. And that's
yes,
very
I think
important.
we have to look at all that.
Thank you very much for visiting.
Well, thank you for
Appreciate
inviting me.
Good to see you.
It's always a pleasure.
Good. We'll be seeing you throughout the meeting.
Okay, I look forward to it.